Super. So we wait for a minute or two and then we start.
Wonderful. Thank you.
So meanwhile, I share my slides. And please let me know if you can see my slides fine.
Yep, I can see them. If anyone's having any issues, drop us a message in the chat and we can fix that. But if I can see them, I'm pretty sure everyone else can. Thank you so much, everyone who's joining for our first webinar. We'll get started in just a bit when we're sure everyone's here.
Okay, do you know how many people are expecting you to join today?
And there might be another few, but this is more than, this is a good amount, I think, from those that registered. So probably a good time to start to make the most of the time that we have.
Okay, super. So good day, everyone, and thank you for being here. Thank you for joining us for our first webinar. My name is Mercede Erfanian. I'm a neuroscientist, and today, alongside Rebecca Howard, we will delve into the insights provided by one of the latest research studies on misophonia. Following our discussion on the article, Rebecca will share her experiences with cognitive behavioral therapy, or CBT-based treatment program that she received in Hashir International Clinic. I'd like to take this opportunity to inform you that these webinar series are organized on a monthly basis, and we encourage you to stay connected for upcoming sessions if you find this session helpful. These webinars are brought to you by Hashir International Institute, and at the end, we will have a few minutes for Q&A. Thank you for your attention in advance, and let's begin our exploration into the world of misophonia research. The study I'm going to be talking about has been done by our colleagues at Sussex University, and it is titled Mental Health Difficulties in Children Who Develop Misophonia, and examination of ADHD, depression, and anxiety. I believe there is no need for an extensive explanation of what misophonia is, as most of you know what misophonia is very well. However, I would like to emphasize the definition put forth by the consensus article that was published last year. And according to this definition, misophonia is defined as a disorder characterized by a reduced tolerance to specific sounds or stimuli associated with such sounds. We all know that misophonia includes a broad spectrum of trigger sounds alongside physiological symptoms, such as increased heart rate, physical symptoms like muscle tension, behavioral symptoms like fleeing, blocking ears, and so on, and emotional symptoms like extreme anger and irritation, and finally, cognitive attributes like hyperfocus, inhibition control, muscle tension, behavioral symptoms like fleeing, blocking ears, and so on, and emotional symptoms like extreme anger and irritation, and finally, cognitive attributes. I think somebody's microphone is not muted, so I can hear my own voice.
Yeah, you carry on. Let me see if I can. Here we go. Yeah, see if that's working for you now.
Okay, yeah, that's fine. And finally, cognitive attributes like hyperfocus, emotion dysregulation, as well as inhibition control. Now, most of research on misophonia has centered around adults, but there is an important study shedding light on its impact on children aged 10 to 14. That was done by the same group. The findings reveal that these kids experience significantly lower well-being compared to their peers. This emphasizes the need for more research and clinical support for misophonia in children. So the study I'm going to be talking about today is based on an longitudinal study of parents and children, involved 4,253 adults from the children of the 90s cohort, and the data that they were collected were participants when they reached the age of 28. They checked for misophonia in late 2020 and early 2021. Out of these participants, 333 had misophonia and 3,920 did not. They call them misophonic versus non-misophonic groups. The analysis included childhood data, including diagnosis of ADHD, anxiety, and depression, with specific time points between the age of 7 to 15 and 16 years old. Basically, this was a retrospective study in which they looked back at the history of mental health of their study participants at different ages that these individuals reported, and also their parents. And the data initially was collected for a different purpose, but they used this data set for their own study. And a lot of apparently papers were published based on this data set. Like I said, the study looked at mental health conditions like anxiety, depression, and attention deficit hyperactivity disorder, or ADHD. The researchers speculate that anxiety and depression traits may already exist in young individuals with misophonia, given the connection between misophonia symptoms and a decline in quality of life during adolescence and adulthood. They also tentatively explored a potential link between misophonia and ADHD tendencies, considering the known connection between ADHD and sensory sensitivities in general. And I think one of the reasons why the focus on these three conditions is because throughout literature, we have learned that anxiety, depression, and ADHD have high comorbidity and also high overlap symptoms with misophonia. To gather their insight, they use measures like the development and well-being assessment and the short mood and feelings questionnaire assessing mental health conditions at different ages, and Sussex screening for misophonia. In essence, this study sheds light on misophonia and its impact on children. While examining data from adults, the researchers aim to understand when mental health conditions associated with misophonia emerge. So this study is a step towards understanding and providing better support for those who may have struggled with misophonia since childhood or developed misophonia later in life. Like I said previously, they had two groups, misophonic versus non-misophonic. They also consider factors like age and different time points in childhood. We know that, for example, age and gender are two important factors when we look at different characteristics in public. The results revealed that there was no difference between the two groups considering the likelihood of ADHD. This means that based on their ADHD likelihood and trajectory, individuals with misophonia were found to be similar to those without misophonia in this study. They also conducted another analysis, this time focusing on likelihood of being diagnosed with an anxiety disorder, and the results revealed that several important findings. The first finding was that they observed that children generally became more anxious as they got older, which is pretty intuitive. And this was regardless of whether or not they had misophonia. We know that we all live in a very complex environment, and the older we get, basically we have to deal with all this complexity, and obviously the baseline anxiety level will go up, especially if we don't know how to deal with all these stressors coming to us from our environment. Additionally, females tend to be more anxious than males, which is also consistent with general expectation. If you look at the literature regarding psychopathology and psychiatry, you will see that women are in general more vulnerable to affective disorders such as OC-related disorders, depressive disorders, and anxiety disorders. Crucially, the study found a significant difference between individuals with misophonia and those without in terms of anxiety levels. The study also discovered that the difference in anxiety levels between the two groups became significant around the age of 10. And as you will see, at age of 10, you will see these two lines. One of them is darker, which represent misophonic group, and another one is lighter, which represents non-misophonic. And at age of 10, these two lines sort of drift apart, and the gap sort of grows as they get older. In addition, the researchers look at the likelihood of depression in individuals with misophonia and without. They consider factors like age and different time points in childhood. And the results indicated that mental health symptoms tended to worsen with age, and also female generally had higher levels of mental health symptoms compared to males. Interestingly, when comparing individuals with misophonia to those without, the study found that misophonic individuals scored slightly higher in their likelihood of depression. However, the difference just missed a statistical significance. So the researchers explored this further in their second measure of depression to see if the finding holds. This time, they focus on depressive symptoms rather than likelihood of depression in these individuals. They consider, again, gender and different time points during childhood, including 9, 11, 13, and 16 years old. The results show a similar pattern to their previous depression measure. Just like before, they found that depressive symptoms tend to worsen with age for all participants, regardless of their misophonic diagnosis. And additionally, female generally had higher level of depressive symptoms than males, and the difference became more pronounced as they got older. Importantly, this difference was evident from the earliest age they examined, around the age of 9 years old, and it remained consistent regardless of gender. In essence, the studies suggest that children with misophonia may experience higher level of depressive symptoms from the young age compared to their peers. As you will see, these two lines never met each other, and there is a gap between those two lines, which means that there is a difference. So what I have reported so far was reported through their parents, because these kids were below the age of consent. So normally when we deal with children below the age of consent or 18 years old, for example, in UK, we normally collect this data via their parents. But they also look at the data that were directly reported by children, focusing on time points at ages 10, 12, 13, and 16. The results mirror what they found in the data collected from parents. They observed a significant pattern. Depressive traits tended to increase with age, and females generally reported higher level of depressive traits compared to males. The interaction between time and gender was also significant, suggesting that the difference in depressive traits between female and males became more pronounced as they got older. Importantly, the researchers once again found that children with misophonia showed greater depressive traits compared to those without. And these findings was consistent across both parent-reported and child-reported data, indicating that children with misophonia may indeed experience higher levels of depressive traits. To sum up, in this study, the researchers investigated whether adults with misophonia experienced mental health issues during childhood. They conducted a detailed analysis using data from a group of participants in southern England. The study included screening adults for misophonia at age of 28 and examining their childhood data for signs of mental health conditions such as ADHD, anxiety, and depression. The results showed that children with misophonia had notable difficulties with anxiety and depression. Specifically, they exhibited higher symptoms of depression as reported by both parents and children themselves. The likelihood of depression diagnosis was also higher in misophonic group, and moreover, children with misophonia showed a greater likelihood of an anxiety diagnosis encompassing various anxiety conditions. This finding suggests that Misophonia may be linked to mental health challenges in childhood, particularly in anxiety and depression. Identifying misophonia in children could serve as an indicator for potential risks of anxiety and depression, emphasizing the importance of early intervention. However, the study obviously acknowledges some limitations, such as inability to confirm misophonia in the past or during their childhood, and also preliminary nature of the findings. So, as my final slide, if you or a loved one is grappling with misophonia, clinicians and healthcare professionals extend their support at Hashir International Specialist Clinic. Hashir Clinic is dedicated to providing professional assistance to individuals dealing with misophonia, granted a wealth of clinical observations spanning over a decade. Additionally, Hashir Clinic invites your interest in exploring their CBT or cognitive behavioral therapy course. Feel free to reach out and let them guide you towards effective solutions for misophonia. Thank you very much for your attention.
Thank you so much, Mercede. That was fascinating. I think, are we leaving questions until the very end? Is that right?
Yeah, like I said, at the end of the session, we can get the questions. But I would like to also now hear more about your experiences on CBT.
Yeah, of course. So I'm a patient support officer at Hashir International. That means I provide informal sessions with patients who are undergoing a treatment program with us. We talk about their progress, their challenges. I offer my perspective and my approaches that they may not have tried yet. But I guess what's kind of unique about those support sessions that I give is that I'm giving a perspective from someone who has misophonia. And as Mercede kind of mentioned at the start, I went through a full CBT-based treatment program with Hashir International 2 years ago now. Kind of lose track of time a little bit, but that's kind of how I'm able to offer that perspective with them, relate to them. My first dealings, or the first time I ever heard about Hashir International, it was when I was looking for support for myself as a patient. I guess to give my own kind of personal background to that, I've, misophonia has been a part of my life since, maybe I was 11 or 12, I think was when I first realized that I had such severe and different reactions to sounds compared to my friends and my family. At that time, I had no idea of the word misophonia, whether it was even known that much outside of the scientific community. I don't even know. This was, maybe 15 years ago now. And my trigger sounds were, what could be described as kind of quite common trigger sounds: eating, sniffing, coughing. I have lots of very vivid memories of it having huge impacts on dinner time with my family, or traveling on public transport, living even, at university in shared accommodation was constantly impacted by this sensitivity to sounds. And I guess the way that I coped with it then, without having had any kind of treatment, was I avoided situations. I basically wore headphones or earplugs as much as I could. So while I was sleeping or traveling outside, I always had some kind of wall between myself and sounds. And that just became normal for me, I think. There didn't seem, to my knowledge, to be anything I could do about it. It kind of reached a peak for me when I was, an adult. I was living in a city and felt that moving to the countryside was going to have a significant change. I kind of thought, it'll be quiet there. There's no way I can be affected by traffic sounds, someone else's music. I had an idea that that would solve my problems. It didn't. Misophonia was very much still a part of my life, and I realized that I needed to be proactive. I found Hashir International and started a CBT program with them. It was not like anything I'd ever tried before. I hadn't had any form of therapy or talk therapy, and there's certainly an element of digging into a lot of the negative thoughts that are your reactions to misophonia. And it was challenging and it was tricky, but I think I threw myself into it knowing that it was going to have or could have such a positive change in my life. So I did the homework and the sessions. I tried to be consistent, and a lot of that involves becoming aware of what you're thinking in reaction to sounds. I'm not going to explain CBT in detail here. I'm not qualified to do it. I can give my personal perspective, but in short, I kind of gradually became more aware of what I was doing to avoid the sounds and the effect that was having on the next time I heard that sound. So I did the sessions, the weekly sessions, kind of spread out gradually until they were monthly, and then even more spaced out than that. And I just realized it was kind of almost in the background had been building my tolerance of sounds, and the noises that I was trying to avoid were happening, but I wasn't getting that kind of knee-jerk reaction of fear or disgust. And I kind of, it almost was happening in the background, and there were the moments of reflection where I thought, oh, I haven't heard that sound in a while that had been affecting me. And then I realized it was happening, but it hadn't been focused on by my thoughts. So fast forward to now, this is around 2 years later, and I have misophonia. It's always going to be a part of my brain and my life, and maybe once a month or twice a month when I'm very run down or tired, I notice that I'm focusing in more on sounds and feeling more reactive, but I don't even know where my headphones are anymore, which is a really nice feeling. And as well as that, personal kind of accomplishment of feeling like I've got rid of the routines and the walls that I'd built around myself from sound, I get the opportunity to speak to others who are in the middle of their, CBT program or considering it, and we get to kind of relate to each other. And I hope to offer kind of a bit of guidance and perspective so that they can kind of, reach a point that I feel really fortunate to have reached with myself and my own misophonia, and the control that it has on my day-to-day, or rather kind of the lack of control that it has over my enjoyment. So that's it in a nutshell. Maybe I'll leave it there because I could probably talk for hours about the many benefits it's had for me. But that's kind of my experience, my perspective on misophonia.
Yeah, cool. Thank you so much for sharing your experiences. So I would like to kickstart with a question, and then we'll give more time to our participants to ask any questions if they have. I wonder what you used to think and what kind of internal dialogue you had before the treatments, and how this internal dialogue really changed after finishing your CBT sessions.
So when it was a noise like coughing or eating or sniffing, it was very person focused. The thoughts were, that's disgusting. How are they doing that? Why are they doing that? When will it stop? Why are they being so loud? That's disgusting. Those kind of, it felt very targeted and very personal at the person making the noise. I also found, like I said, I moved to the countryside, kind of searching for quiet, and my misophonia kind of seemed to also focus on non-human sounds. So a nearby bollard that would move up and down, a very mechanical noise, became a trigger for me. It was just a hydraulic kind of hissing noise. And I realized, okay, it's not focused on a person. I don't have these thoughts of why are they doing that? It's an inanimate object, but still my misophonia was able to become, these furious reactions. And in that case, it was like, why is it happening? Why is it so loud? Why is it doing that? And I think the realization that it wasn't focused on a person made me think, okay, this isn't something I can avoid. It's not like, it's not someone else's problem. This is something happening deep inside my head to resolve. So that was kind of the before. And then, now, like I kind of mentioned, if I know that the noise is happening, like that bollard noise, it still occurs. And when I hear it, the thoughts that go through my head are more like, oh, there's that noise, or oh, I haven't heard that today. That's the first time I've heard it because I haven't been tuned into it. If I really kind of think about what that thought pattern is, it's very neutral. It's like not angry, not good, not bad. It's just kind of like, oh, there's a noise. And I guess that's kind of my glimpse into maybe that's what it's like when people without misophonia hear a noise, hear a sniff or a cough. It's like, there's a noise. Just an awareness of it, really.
Okay, yeah, interesting. Of course, I would like to hear more about the CBT protocol that is focused on misophonia. But since we are running out of time, it's best to get some questions if anybody have any question. Otherwise, we will call it a day. We give people like 15 seconds to ask the questions because I don't see anything in the chat.
Yeah, there's nothing in the Q&A section. Or if you have a question, you can, if you click the raise hand button, and otherwise pop something in the chat. We'll give it a second, and then if not, we'll call it a day. Let's see.
Yeah.
Oh, we have one there.
All right.
See that, Mercede?
Yes, can be CBT done remotely? Please tell people if you were at clinic in person for every session that you did CBT, or that was partially online, or it was total online.
Yeah, mine was completely online. So all video sessions. So yes, from my experience, it can be done remotely and effectively. So yeah.
Okay.
You're welcome. Cool. Thank you for your question.
Lovely. So as I said before we wrap up, we are going to continue with this webinar series once a month. And our next series is going to be on December 15th. And we will advertise it on different platforms. So stay tuned. And thank you very much for joining us today.
Perfect. Thank you very much. Bye.
Bye.